Okay. Hello, my name is Madison Haynes, and my presentation is on Mycobacterium tuberculosis. Okay, so first to start, I'm going to be talking a little bit about its structure and mainly the main things that really contribute to its pathogenesis and contribute to why certain tests are used in diagnosing tuberculosis. So the main things to look for are these thin rods, which are bacilli. That's the shape of them. And their cell wall is largely composed of these complex glycolipids, also known as mycolic acids. And these acids are very waxy and make the cell resistant to drying, disinfectants, strong acids, and strong alkalis. And that's why acid-fast staining is used in basically identifying and looking at M. tuberculosis. And you can see this in the bottom right picture. And a little bit more about them. They're strict aerobes, and their generation time is 12 to 16 hours, and the incubation period is 2 to 10 weeks. So I know this is a little wordy, but stay with me here. So the pathogenesis of M. tuberculosis it's primarily inhaled and taken into the lungs, into your alveoli, and your alveolar macrophages basically take up the M. tuberculosis. And usually the phagosome fuses with the lysosome in order to kill whatever is in the macrophages, but mycolic acids of M. tuberculosis basically prevents this fusion from happening. And so eventually the M. tuberculosis leaves the phagosome and it's multiplied in the macrophage. And during this, more macrophages and more lymphocytes go to the site. And at that site, even though they're trying to help, they almost don't in a way, because it also, since there's more macrophages coming, it also gives the M. tuberculosis more macrophages to basically multiply in. And usually, especially in healthier people, this tubercle is formed. It's a fibrous capsule, and it creates this calcification called Gone foci, which basically keeps the M. tuberculosis in check and doesn't really allow the M. tuberculosis to escape. And when the macrophage dies and the M. tuberculosis is released, it's still in this tubercle, and the pH is low and there's low oxygen. So eventually these particles die. And sometimes they don't. If they're still surviving in there, but they're encapsulated, you basically end up with LTBI, latent tuberculosis infection. And if the tubercle ruptures, it's called TB disease. Okay, so signs and symptoms of TB, it really depends on where in your body it is and what kind of TB you have. If you have latent TBI, there are no symptoms. You won't necessarily know that you have it. But with TB disease, you see many more symptoms, and it can affect usually your lungs, like I said, because of the pathogenesis being, because the TB is inhaled. You usually have pulmonary TB, but it can also affect your lungs, your kidney, your brain, and even your spine, which is also called extrapulmonary TB. So the symptoms, whether it's pulmonary or extrapulmonary, there are similarities like loss of appetite, unexplained weight loss, night sweats, fever, and fatigue. But there are a little differences with pulmonary. Since it's with your lungs, you're going to end up with a cough, probably, and maybe even coughing up blood and chest pains. But with extrapulmonary TB, the little differences depend on where it is. If it's in your kidney, you might see blood in your urine. If you have TB meningitis, you might have a headache, confusion in your spine, back pain, larynx, hoarseness. Okay, so next comes diagnosing of TB. So this is very tricky because I'll talk about it a little later, but there are a few different ways to diagnose TB, but there's not necessarily a right answer for what to start with. There are certain paths people usually go down, but it's not 100% followed. There's not like a strict way to do it. But the most common tests for diagnosing TB are the TST skin test and the INGRA blood test, followed by other supportive tests like nucleic acid amplification chest x-rays, or culturing. And so, like I said, I would talk later about it. So the method that you end up using really depends on a few things like the reason for getting the testing, whether there's symptoms or no symptoms, maybe even the cost, because a skin test is cheaper than a thing like x-rays. And with age, the TST test is preferred for children under 5, and your health really affects which tests you might want, because there are certain tests that are a positive is taken more seriously, you could say, and that might be the go-to path for someone that's immunocompromised, who it's literally very, very critical to get them diagnosed because their immune system can't really fight for them as well, so they're more likely to die from TB disease. So it's really important that these people get a positive diagnosis when they need it. And in terms of the TB skin test, TST skin test, and the INGRA and the blood test, it's generally not recommended to use both tests. So it's usually either or, and then the follow-up test. So starting with the TST, tuberculin skin test, also known as the Mantoux test, you start with 0.1 milliliters of tuberculin, purified protein derivative, PPD, and it's injected into your lower arm. So this PPD usually comes in the form of the brands of Aplasol or Tubersol, and it's the sterile aqueous purified protein fraction. Basically, it's not going to make you sick. It'll elicit a reaction, but it's not going to give you TB. And it's isolated from culture media of human tuberculosis. So after this is injected in your arm, you wait 48 to 72 hours before reading the results, because that's when peak intensity for the test occurs. And you'll usually see this firm swelling called induration, and this injection site, this swelling, is measured with a ruler, and based on the millimeter outcome, a positive or negative result is given. Okay, so I couldn't really fit this into the PowerPoint, so I had to put a link instead. And this is basically a little pamphlet on the test. You can see a little bit there about how to do it. And I just wanted to focus on the look of this induration. So there might be some reddening, and there's going to be it's going to be hard. That's one of the main things that is highlighted. And here there's this tuberculin ruler that's used in order to measure how big the induration is, how large. Okay, so back to this. Okay, so basically a positive is given differently depending on what's the risk of the patient. So a healthy person with no risk, 15 millimeters is pretty standard for not necessarily diagnosing TB, but giving a positive to M. tuberculosis being present. But only 5 millimeters is needed for someone that has suppressed immunity, or someone has already had previous x-rays that suggest TB, because their immune systems are compromised. So the site of the induration it's not attacked as fast as someone without health risk. So 5 millimeters might be all there is, if that makes sense. And then 10 millimeters is used for other people with kind of changed immunities, like drug users or someone that has other medical conditions, or children. And also if you're from a country with high rates of TB. So if you get a positive, this doesn't mean you have active TB, but it just means that you have TB within you. So you could be infected with it, and you could have latent TBI. And there are also false positives that occur, which may occur because of this vaccine called BCG vaccine. And so after this, usually x-rays might be taken, sputum samples might be taken, and an AFB test given. So if you have a negative, it's usually no swelling has occurred, and latent TBI or TB disease is not considered likely. But 20% are false positives, and like I said, immunocompromised people have altered reactions to this, so they might get a negative, but their body just can't react fast enough to bring like T cells to the site to create induration. And also, if the TB infection is only recent, might create a false negative, and very young age, younger than 6 months, other viruses or vaccinations, and incorrect method of giving TST, or incorrect measuring, which is basically human error, that could create a false negative. As far as blood tests, it's called I definitely forgot a letter, I'm sorry. INGRA, interferon gamma release assays. So basically, interferon gamma is produced in the body in response to M. tuberculosis, and this test is basically a way to detect the interferon gamma. And the test is pretty similar in results compared to the TST skin test, but it's faster and more specific. So this might be an option for someone, like I said, that it's more time sensitive to get them a diagnosis. And it's the preferred method also for those who have received BCG vaccine, because those people can also get a false positive on the TST test that basically messes up the results. So a blood test is much preferred for people that get that vaccine. So what now? So chest x-rays / radiograph. These are usually used to exclude pulmonary TB disease in someone who really has no risk or symptoms for TB, and they might have had a positive reaction or a positive result in the TST or the INGRA test. And so here in this picture, you can see like there's this like cloudiness, this little circle. This is basically a cavity that is due to TB, and that kind of image may be used to not necessarily diagnose TB, but a very good indicator of it. And it can't really be used to determine latent versus active TB. So a sputum collection or an AFB smear are necessary afterwards. Here's a little more better pictures. You can see the cavity here, circular region, this little cloudy thing, and this axial view even more clear. See this little pocket and the light area surrounding it. And so basically, when I talked about earlier about the tubercle, if that tubercle basically bursts and it enters the bloodstream, it can get in your tissues and it creates these white granules, which are called or which is called military TB. You can see instead of it being localized in like one little circle, the TB is like everywhere, which is insane and basically is super, super dangerous as it looks. Okay, so after that, sputum samples are taken, also known as phlegm, and it helps identify if TB disease is present, and is also used to determine like the successfulness of a TB medication in eliminating the TB. And it's not the same as saliva. The sputum contains more pus and mucus and really, really comes from your lungs, and it'll have more of the tubercle bacilli in the sputum than in something such as saliva. And this sputum is used for smears, nucleic acid amplification testing, and for cultures. And it's usually collected one of 4 ways. Usually people can cough. They take like a deep, deep breath in and like cough up, cough, 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 and cough up the sputum. But some people can't do that. So there's induced sputum, where this warm saline aerosol, which is about 3 to 5% salt, is like put into your lungs, and that induces your ability to produce sputum. Or there's bronchoscopy, which might be more so done on someone that's already considered non-infectious, but it can be done on someone that has infectious TB. It gives more insight on what's going on in the lungs, if you can see down there, but it's a lot more dangerous when it's infectious to do that. There are like more protocols to follow, like making sure there's like aeration in the room, a good airflow, and like people are wearing the proper gear, because like I said before, this is inhaled, and if you're in a small room giving a bronchoscopy, someone's mouth is open, not a good thing. Without the proper things, without the proper basically techniques being used. And there's also gastric aspiration, which is usually used especially in children where not enough sputum is able to be produced, and this thing basically goes into your mouth or your nose and into your stomach, where they collect sputum, which might have been like coughed up in the throat and then swallowed. Yeah. So using that sputum, next thing is an AFB smear, acid-fast bacilli smear. It takes 1 to 2 days, and the presence of acid-fast bacilli here really shows the likelihood of TB, but it's not definitive, because in acid-fast smears, other mycobacterium might appear. So if you see in the bottom right hand picture, there you can see how M. tuberculosis is on top, and M. bovis and leprae, atypical mycobacteria, those all might appear on an acid-fast bacilli smear. But so it's not really, like I said, definitive of TB, but you can kind of assume it's more presumptive based on the other tests. And so, like, even a lot of people with TB might have a negative AFB smear, and since this can't be used to officially diagnose tuberculosis, it's often done in tandem with nucleic acid amplification testing and cultures. But with 3 negative smears, it's usually concluded that TB disease is not likely. And in the top right-hand corner, you can see the smear classification results. Basically, using magnification and counting, you can determine whether someone is likely to have TB and whether it's infectious or not. So, like, strongly positive, like probably have TB, probably very infectious is like the most you can get. But if there's like nothing on there, It's negative and it's probably non-infectious, but like I said, some people have TB and they can appear negative on an AFB smear. So next is nucleic acid amplification testing. It amplifies certain DNA and RNA in the microorganism, and here it would be the TB. And an example is PCR. And this testing takes hours, and it's pretty reliable, and it's an accurate positive, unlike some of the other tests. And so basically, if you come in and it's unlikely that you have TB disease, a positive is very suspicious, and it's likely a false positive. If you're unlikely to have TB and this test comes out negative, it's just more diagnostic support that you probably don't have TB. But if you're likely to have it, a positive is diagnostic support that you probably have TB. And if you have a negative, it helps support that maybe you should be looking at something else to support your TB diagnosis, like basically a false negative. But this can also be used along with 2 negative AFB smears to contribute to the fact that your TB disease diagnosis is unlikely. Okay, and the next thing is culture. So a culture is considered gold. It's a very reliable positive, and like basically confirms TB disease, but it does not rule out TB, especially if you might have TB in different parts of your body. But during this culture, for this culture, 3 sputum samples are taken on different days, usually 8 to 24 hours apart, and possibly a blood sample or a lung sample may be used in this test as well. So it really depends how you're doing the culture and whatnot. But some say 4 to 14 days is typical, but the culture media that's on the right is usually what's typical, and that's 4 to 6 weeks, but the culture can take even up to 12 weeks. And there's also a rapid version though, which it only takes 24 hours. So this Lowenstein-Jensen medium is a special culture media. It's a slant. Like I said, 4 to 6 weeks it takes, 37 degrees Celsius incubation time and temperature. And it's composed of a whole egg, asparagine, glycerol, malachite green. And the malachite green is really used to inhibit like other things from growing on the medium, making sure we only get TB. And what happens is this growth, if it's positive, you have this growth, this rough, dry, yellow-colored bacteria, which is presented here. You can see it's all clumped together. This is like a zoomed-in version under microscope, and this is a version of just looking with your eyes. You can see the growth on the green slant. And so, basically, both nucleic acid tests and cultures are considered critical points in diagnosing and treating TB disease, because a positive in either is like it's supposed to be reported to the state or local health department, because it's very, very likely that you have TB disease, and we want to make sure that's contained and not spreading. So it's important to alert the local state health department. And a negative might be critical in starting to look in other directions other than TB. Okay, so as far as treatment and prevention, so if you have TB disease, a typical treatment involves a combination therapy. Basically, with TB, there are really high cell numbers, which means a higher rate, higher chance and more spontaneous mutations that might include resistance. So basically, with combination therapy, this really helps in preventing resistance. Sorry, excuse me, I had to get some water. So the most potent TB drugs are isoniazid, INH, and rifampin. RIF. They're the most used ones in treating TB. But there's also pyrazinamide, PZA, and ethambutol, EMB. And these are all first-line drugs. And what's recommended is these first-line drugs are taken for 8 weeks, and then INH and RIF are taken for 18 more weeks. And basically, the biggest contribution, in addition to this combination therapy that prevents the spread of resistance, is this newer thing called directly observed therapy, DOT. Basically, this is just helping, it's like healthcare workers making sure people are taking their medicine, taking it right, taking it for the whole course, so that resistant strains don't develop, and so they might, even if they think like, hey, I don't have TB anymore, I'm good, and that might be wrong. So DOT has really been a lifesaver and really helped contribute to TB decreasing in the US. And so treatment for LTBI is basically, it's focused on like prevention of it turning into full-blown active TB disease, and especially critical for those with HIV. And it's usually recommended to take INH for 9 months. And there are like a few different recommendations for treatment. It really depends on the doctor and what they think for your case. But there's this thing called 3H, and it's basically taking three different drugs, like each week for like 4 months, I believe. And this also, what contributes to deciding what treatment to do for someone is a drug susceptibility test, which it says on the right, to basically better treat the patient. And so this picture you might not be able to see well, so I also included a link. But this is from the CDC, basically in a treatment regimen that's recommended and changes depending on age. Here you can see adults, like children, adult children, and like I said, 3 is 3H. Oh, my bad, 3HP. Take it once weekly, 3 months or 4 months here, daily. Just a little tidbit if you want to look at it. Okay, so back to the presentation. So basically, drug-resistant TB, DRTB, occurs often, like I said, especially because of mutations and when people don't take their drugs. So first, there's this multi-drug resistant TB called MDR-TB, and it's resistant to the most potent effective TB drugs, the INH and RF that I've talked about previously. So the next move is to go to second-line drugs, which are less effective, but they're more toxic and more money. And the other drug-resistant TB is called extensively drug-resistant TB, XDR-TB. It's more rare and is pretty much resistant to all first-line and second-line drugs, or they might be resistant to first-line drugs and maybe at least one of the second-line drugs. And this is extreme, since it's so rare and it's so resistant to all these drugs, it's really dangerous for someone that's immunocompromised because they're already more likely to die from TB, and now they can't be treated because they have this super rare form of TB. And if either one of these TBs, if you're diagnosed with having either one of these, you're probably going to want to go to a TB expert. Okay, and so prevention of spreading. This doesn't really necessarily apply, but there's a certain tuberculosis, bovine tuberculosis, that is easily killed by pasteurization, despite basically tuberculosis being really hard, like not really being susceptible to like strong acids or alkalis. and detergents and stuff like that. Pasteurization kills it. And so prevention of spreading with LTBI there's not really much to do. You want to be treated for your LTBI to make sure that it doesn't become active TB, which you can then spread to someone. But since it's not active, it's not contagious otherwise. So another form of prevention is especially those with no risk. There's this BCG vaccine that I've talked about before, and it's very, very, very subpar. It's not recommended in the US, and it creates false positives in the TST, like I said. So if you ever do get TB, like that just makes it one step harder in diagnosing you because you can't get a TST skin test. Even though there are a lot of other things, it would just be nicer to be able to use all the tests, you know? And like I said, subpar prevention of TB. It's okay in childhood prevention of TB, but with someone with LBTI, literally, it's pretty bad, to be honest, at preventing it. And the BCG is pretty dangerous also for someone that's immunocompromised. So I would not really recommend that, but it might be good for someone that's in a different country where TB is the rate of TB disease is higher, or the numbers of TB disease are higher. And so that's the end of my presentation. Here are the citations. Thank you for coming to my presentation. Mycobacterium Tuberculosis by Madison Haynes.